And we will now move to the second presentation, which will be by Mathieu Ichou. Mathieu Ichou is a research fellow at the National Institute of Demography in France, Ined, where he's co-head of the International Migrations and Minorities Unit and a member of the Economic Demography Group. He's also associate researcher at the Observatoire Sociologique du Changement at Sciences Po Paris, and a fellow of the French Collaborative Institute on Migrations. He's also very much involved in the CO2 study, which aims to study living conditions, health, and the impact of discrimination in different areas of life on immigrants and their children. And he's conducted research on social mobility across 3 generations in Native and immigrant families, and he'll talk more specifically about discriminations with regards to healthcare. Hello, Mathieu, and welcome.
Hi, Maria. Thank you so much for the nice introduction. Thanks for the invitation. I'm very pleased and honored to be part of this first international conference by the CIMigration. I'm also very pleased to follow James's very inspirational and thought-provoking talk. So I'll be talking about a paper that I'm co-authored with Josh Rivenbark from Duke University. The title is Discrimination in Healthcare as a Barrier to Care, Experiences of Socially Disadvantaged Populations in France. As you'll see, I will specifically focus on immigrants, their children, and even more specifically on ethno-racial and ethno-religious minorities. So here we go. So as a very general background, my talk will be relatively general. I think so. It's probably good that it's the first of the session. So as James highlighted in his talk, and as the literature shows in a wide variety of ways, there are strong evidence of links between experiences of discrimination and worse health. In the literature, it's possible to distinguish between 2 different sort of pathways that link discrimination and worse health. The first one being a direct pathway, basically experiences of racism and discrimination is psychologically and physiologically stressful and impacts the mind and the body directly in adverse ways. So for example, a literature review of 2003 stated that direct encounters with discriminatory events contribute to negative health outcomes. And there is a direct sort of bodily response to discrimination and racism. There are also indirect mechanisms, and that will be the topic of my talk today. That is, there is existing evidence that experiences of discrimination or perceived discrimination are associated with changes in health-related behaviors, such as diet, exercise, sleep, substance use and abuse, etc. So discrimination can make you change your behavior that are in turn negatively associated with your health. And in this talk, I'll specifically focus on one such behavior that we think has received relatively less attention, namely the use of the healthcare system itself. Whether experiences of discrimination in the healthcare might have adverse effects on people, especially people who are victims of discrimination, in terms of their use of the healthcare system, which would in turn lead to lower, worse health outcomes. So the mechanism would be obvious here. It's almost self-explanatory to expect that if the healthcare setting is perceived as a setting of increased risk of discrimination, then almost as a defense mechanism, it might be better to avoid it, or at least you are more likely to want to avoid it if you feel that you will likely be discriminated against in such settings. So there, to our knowledge, there is relatively little literature that directly assess these relationships, but we found a sort of parallel line of research that very much goes in this general direction about HIV patients and HIV-related stigma, which shows that in settings, especially healthcare settings, where patients perceive that there is a high level of stigma associated with their HIV condition, then these settings are found to have lower retention of their patients.
Mathieu, sorry, your slides aren't moving.
Oh, that's
sorry for disturbing, but
yeah, no problem.
We all want to see it.
Sure. So nothing is happening. I will perhaps try to stop sharing and reshare them again.
You have to, I think, be put the full screen on as well.
Yeah, yeah, that's what I was doing. But okay, okay. How about now? Do you see something moving?
Well, we see the next. Yes, excellent. Thank you.
Perfect. Okay, so it's too bad you didn't see the arrow moving. But I don't think you missed too much. So I was talking about the direct and indirect pathways and the fact that we were focusing on discrimination within the healthcare setting. So I was saying that there is a parallel line of research on HIV positive patients, which relates the level of stigma against these patients and the lower rate of retention of those patients in healthcare settings. We actually found one previous study that was most related to what we wanted to do. The setting is in Sweden. It's a Swedish mail survey, so by mail, which shows that there were higher rates of perceived discrimination in healthcare for women than for men, and that these higher reported discrimination over the past 3 months before the survey were associated with higher odds of foregone care over the same period. So those who reported discrimination over the past 3 months were also those who were at more risk of renouncing care. So we found this study very interesting and stimulating, but perhaps a couple of limitations are to be reported. First, that it only focuses on discrimination reported over the past 3 months, which is a very short window of time and probably misses a lot of the past experiences of patients. And second, even though very informative and interesting, it only focuses on gender differences in discrimination and foregone care, while we want to extend this to other demographic groups. Well, I'm assuming that the PowerPoint works now. So in our paper, we have 2 research questions. They're very simple and straightforward. The first one is we want to know what is the prevalence of A, reported discrimination within the healthcare setting, and B, the risk of foregoing medical care across a range of social groups defined by gender, immigrant generation, race, ethnicity, or proxy for it, and religion. So that's the first very descriptive question. And then the second one is, to what extent disparities in foregone care, so the rate at which people renounce healthcare, can be explained by discrimination in healthcare across these groups. So the basic question is, in groups that are more likely to renounce their care, are they also more likely to be discriminated against? And can we statistically link these two phenomena? Okay, just a very quick background on the French context. I'm going to be very quick here, but as you all probably are well aware, there is a large immigrant and immigrant origin population in France, which is a ethnically and religiously diverse society. It is associated with what some people have called the Republican model of integration, which is sort of ideological, philosophical model on how the state and ethnic minorities should relate. I won't go into the political philosophy of the French polity, but that has direct consequences if one wants to study discrimination in healthcare. First, race, ethnicity statistics are not used for official purposes in France. And so it's certainly not as they are used in the UK, for example, as we saw in James's talk, or in the US, or in other European countries, such as the Netherlands. That has impeded research on racial and ethnic minorities in the healthcare system and discrimination within that setting. So overall data on ethnic minority groups is limited, even though discrimination is not. There is a relatively recent meta-analysis by Lincoln Quillian and his colleagues that show that France is, unfortunately, it's a comparative, internationally comparative study that shows that in terms of discrimination in hiring, France is at the top of that dark ranking. So there's a big discrepancy between the sort of absence of ways to measure ethnicity and discrimination directly, and yet a pretty dire situation in that respect, especially in comparative perspective. Anyway, the last element of context is that the healthcare system, despite all its limitations in France, is in comparative perspective of relatively high quality, and there is universal insurance coverage. So economic resources should not be, especially compared to other countries, a major obstacle in getting healthcare. There are, of course, qualifications to that, but in comparative perspective, that is the main message. Okay, the survey I'm using is the Trajectoire et Origines survey, Trajectories and Origins, that has been that was designed by Ined and collected by INSEE in 2008-2009, and it is, of course, I'm biased, but it's of course a great survey that is nationally representative of French adults living in metropolitan France, aged 18 to 59. It's a relatively large sample, and it has the unique feature of oversampling immigrants and children of immigrants with more than 8,000 people in each group. And you can use weights to then make these oversamples representative of the general population. And it's a 1 hour face-to-face questionnaire, so high quality by professional surveyors, which includes a relatively small health module. As I'll say at the end, the second edition of the survey has developed this module quite a bit. So the measure we are using for this paper are the following. We measure discrimination in healthcare through the following question. Has a doctor or other medical care worker ever treated you less well or received you less well than other patients? So it intentionally does not mention racism or discrimination in the wording of the question. To sort of relate it to James's talk, it's probably, it's the sort of interpersonal dimension of discrimination or racism that we want to tap into with this question. The second important variable, it's our main dependent variable, the thing we want to ultimately explain, is foregone healthcare. During the last 12 months, have you foregone healthcare for yourself? And then in the questionnaire, there is a little explanatory note that says that if the respondent is confused, you have to explain that it's care that was needed, but that the respondent renounced. And about 11% of respondents say yes. It was 4% for the first question. Our group of interest are gender, immigrant generation, country of origin, that means country of birth for immigrants, and parental country of birth for children of immigrants as a proxy for race, ethnicity, and religion. In various models, we also control for age, different measures of socioeconomic background, health status. We control for health status in some models because we basically, it's a way for us to control for exposure to the healthcare system. Obviously, if you have to go 50 times a year to the doctor or to the hospital, then you're more likely, because you're more exposed, you're more likely to be discriminated against just because of the frequency, the mere exposure. So we want to try to control for that to some extent. Okay, first descriptive results. There will be 3 models where we first control for age and gender, then the second model, age and socioeconomic status, and then we add health status in the third model. And it shows the predicted probabilities of reporting discrimination in healthcare. By gender, as you can see in the first model, women report significantly higher rates of discrimination. It's still true in the second model. In the third model, as you see, the black bar became gray, which indicates a lack of statistical significance, but the direction of the effect is still the same. Women tend to report more discrimination in healthcare, but it's no longer statistically significant when you control for exposure. By migration generation, I'll go a bit more quickly. In the first sort of raw model, first generation immigrants, so immigrants themselves, tend to report higher discrimination in healthcare than natives. The effect still goes in the same direction in model 2 and 3, but because of controls, it stops being statistically significant. The difference is no longer statistically significant. The same is not true for what I call origin, which is basically, it mixes children of immigrants and immigrants. And as I said, for immigrants, it's a region of birth of parents. No, for immigrants is their own region of birth, and for their children is parents' region of birth. So as you can see here, the 2 groups that have sort of consistently reported higher levels of discrimination are people from overseas France, so what we used to call dom-tom in French, and from Africa, combining both North and Sub-Saharan Africa. Obviously, these are the racialized minorities, the most racialized minorities in France. And this holds despite the rich set of controls. For religion, when Christian is the reference category, I should have said that the blue bar is always the reference category, to which I compare all the other groups. As you can see here, the consistently more highly discriminated group is the Muslim group, and that is actually enhanced by adding controls rather than decreased. So that's the first basic result. Here are probably in this slide, you can see the most telling result about discrimination. It's that the groups that report higher discrimination in the healthcare are people from overseas France, Africa, and Muslims. Now, what we really wanted to explain in this paper is gaps in foregoing healthcare. So who are the groups that say that they are more likely to renounce care that they need? So this is the descriptive differences between groups without controlling for anything. And then we will relate these gaps to experiences of discrimination. So as you can see, female compared to male report foregoing healthcare more often and significantly so. Same is true for people coming from overseas territories or Africa, and people from mixed marriages. The second generation this time, and again, the Muslim group. So it is striking that those groups who report foregoing healthcare more often are very similar to those who reported higher levels of discrimination. But for now, this is still just very correlational and just putting two statistics together. We'll try to go a little bit further without being having the means to be extremely causal in our interpretation. So we're still careful not to claim causality when we cannot show it, but yet one thing that in multivariate models combining discrimination to explain, including discrimination to explain foregoing healthcare, we show that at the individual level, those who say they were discriminated against in the healthcare setting are the same, at least are much more likely to say that they renounced healthcare, they forwent healthcare. And the size of the effect is far from negligible, because so it's in terms of average marginal effects, that can be read as percentages or proportion. So in the fully adjusted model where we put all the control, basically a person who reports discrimination in healthcare has a 14% chance is 14% more likely to say that they also are foregoing healthcare. I'll go directly to the last part of the result. Now, what we really wanted to check out and to discover is whether the gaps in foregoing healthcare between minority and majority groups, how much of this gap could be explained by reports of discrimination. And so for each contrast, we have that proportion. So for example, the higher proportion of reports of foregoing healthcare for women compared to men can be explained by their higher discrimination rate. 18% of this gap is explained by discrimination. For the contrast between second generation and natives, it's 6% of this gap. For the contrast between overseas territories and people from metropolitan France, 15%. For people from Africa compared to natives of France, it's 22% of this gap that can be explained by discrimination. And now for Muslims compared to Christian, 24%. So in other words, discrimination, self-reported discrimination, seems to play a particularly strong role. Of course, it does not explain everything in differences between groups in rates of foregoing healthcare, but it does explain quite a bit of the gaps between groups. So in other words, it looks like discrimination has a very powerful and unfortunately negative effect in people using the healthcare system, which in turn is very likely to have a negative effect on their health. So basically, that is the mechanism that we think is both understudied and yet very important, that links discrimination to health outcomes. So to conclude very quickly and in very simple terms, we found that rates of both discrimination in healthcare and foregoing healthcare are highest among women, people with origins in Africa, and Muslims. We also showed that discrimination in healthcare could partially explain disparities in foregone healthcare. And that leads to sort of link back to James's talk that very much points to mechanisms at both the interpersonal and institutional level, so the micro and meso levels, for interventions to reduce the gaps in health between minorities and majority. If you want to know more and learn more about these results, we published most of them in a paper, so with Josh Rivenbark in BMC Public Health. And lastly, I want to show the future of this line of research with the second edition of the Trajectoire et Origine Survey, as Maria kindly introduced. I'm co-responsible for this survey together with two colleagues, Patrick Simon and Chris Beauchemin from Ined. And in this second edition, which the field just ended in late 2020, we expanded the health module with many more questions, and hopefully we'll be able to study these topics in much greater depth. Thank you very much.
Thank you very much, Mathieu, for a very interesting and also worrisome presentation, actually, where I guess we have confirmation of things that were probably already thought through, but of course, given the lack of research in France on these topics, it's important to have data that show the differences between different groups in terms of access to healthcare, and the fact that they don't appear to be random.